slide. So I'm going to introduce Dr. Mackenzie Cottrell, and it is a privilege that she is out here. And also, we only moved small mountains to make it happen, as I think she will talk about with one of her projects. She completed her Doctor of Pharmacy and Master's of Pharmaceutical Sciences and a general practice pharmacy residency at the University of Oklahoma. She completed an ACCP accredited HIV pharmacology fellowship, followed by a clinical pharmacology fellowship at the UNC Eshelman School of Pharmacy. She joined the faculty there in 2015 in the Division of Pharmacotherapy and Experimental Therapeutics, and she's the co-director of for the UNC Center for AIDS Research, that's the CFAR, Clinical Pharmacology and Analytical Chemistry Core. Her research focuses on characterizing PK/PD relationships for antiretrovirals and latency reversing agents, and utilizing in vitro and mathematical modeling techniques to identify HIV treatment and cure strategies tailored for specific end user populations. And she's the principal investigator on an NIH-funded research program to characterize HIV PrEP pharmacology within transmission sites in transgender women taking feminizing hormone therapy, which is why she is out here. But I'm gonna now turn it over after that illustrious introduction to Mackenzie, and we're really so excited to hear from you.
Thank you, Jill. And before I get started, I just have to say this is unprecedented for me. This is the very first time I've ever given a conference or seminar type talk in a hotel room. So please bear with me and forgive what I have in the background. I'll try not to be too distracted by it. So as Jill said, my research really focuses on trying to harness the power of modeling and simulation tools to better understand how we can optimize PrEP dosing or PrEP delivery modalities for specific end user populations. And today in this talk, I'm going to go through a few different concepts that are related to both pharmacokinetics and pharmacodynamics, but at the very end, if I have time, I'm also going to go through some concepts of how we can measure drug concentrations in different parts of the body to understand how well our study participants or our patients are adhering to their PrEP regimen. I do also want to start this talk off with a definition. I may not always perfectly use this, but I'm going to try to adhere to the strict definition of efficacy versus effectiveness. So throughout the talk, you'll hear me say efficacy, and when I'm talking about efficacy, I'm talking about the effect of a drug in a very controlled study environment. And when I'm talking about effectiveness, I'm talking about the effect of the drug in the real world. So whether the end user uptakes that option or whether they adhere to that option. And so this is my disclosure slide. Much to my husband's dismay, I have no conflicts of interest to disclose. So as everyone on the call knows, the US FDA has now approved 2 fixed dose combination tablets for use for HIV pre-exposure prophylaxis. Both of these dosing formulations must be taken by mouth once a day. And we know that both tenofovir disoproxil fumarate and emtricitabine, as well as tenofovir alafenamide with emtricitabine, are efficacious for HIV PrEP. And those findings have really come out of 9 large randomized controlled trials. And I'm sorry, I'm going to pause because I got to move my face and put myself way down here so I can see my slides. Oh, I still can't. Maybe I'll just do that. Okay. And those findings have really come out of 9 large randomized controlled trials. I have them tabulated here for you, and I've grouped the trials by the study population that received PrEP in either of the formulations we just discussed. Here in red, you see large studies of heterosexual men and women, and serodiscordant heterosexual couples. In green, you see studies of men who have sex with men and transgender women. And in blue, you see studies of heterosexual women, cisgender women, excuse me. I will try to define that throughout this, but if I forget, please forgive me. And you see with a certain trend pop up in terms of outcomes, in that the studies in women tended to demonstrate futility. And so when investigators of these trials were drilling down into the reasons of futility, they explored the study participants' adherence by objective adherence assessments rather than subjective assessments. And they found that the efficacy within a given trial really scales with the proportion of study participants who demonstrated an objective measure of adherence. Those data are plotted for you with efficacy on the y-axis and proportion of the study population demonstrating adherence on the x-axis, and color-coded, as I just described, by study population. And so these were the first glimpse that PrEP effectiveness may not be the same in cisgender women as other study populations. And I want to review a few more data from clinical trials to speak to that point. The first is a concentration response relationship shown on the graph in the left from iprex-Olay. And here incidence is plotted on the y-axis across tenofovir diphosphate concentrations in dried blood spots that were collected from participants across the study time on the x-axis. And you can see that as tenofovir diphosphate concentrations go up and become associated with dosing behavior of taking more than 4 to 6 doses per week, PrEP is nearly 100% effective. But importantly, even with just 2 doses per week in iprex-Olay, there was an 80% reduction in incidence. Also importantly, we know from iprex-Olay that about 50% of study participants took their dose as recommended. And so these data speak to the fact that within iprex-Olay, likely there were participants who were taking the dose at the 2 to 3 doses per week, or a large proportion of participants taking it at the 2 to 3 doses per week level. So when we scroll over to what adherence looked like in the PrEP study, which was in cisgender women taking tenofovir disoproxil fumarate, you see on this graph, on the y-axis is the percent of study participants at any given point along the study on the x-axis who demonstrated by a biomeasure of adherence, good being more than 4 doses per week, modest being 2 to 3 doses per week, or poor being less than 2 doses per week adherence. And at any given point along this study, about 45 to 60% of cisgender women were taking more than 2 doses per week. Yet despite these somewhat matched adherence levels, the PrEP study was futile in terms of PrEP efficacy, and the iprex study demonstrated about a 60% reduction in HIV incidence overall. We also see in terms of uptake that PrEP effectiveness may differ by user. And to show this, I am showing you data from the CDC that were collected in 2015, which I recognize is a little bit old now. But you can see on the graph to the left that women are disproportionately represented in terms of HIV incidence in 2015. And in the graph on the right, you can see that women are the fewest the fewest number of PrEP prescriptions are prescribed to women, with only about 20% of all PrEP prescriptions in 2015 being written for a cisgender woman. And that number actually decreased by about 17% from 2012. So now that I think I've tried to make the case that PrEP effectiveness may differ by the end user population, I want to go back and review pharmacology, the pharmacology of PrEP. So as I said, there are two formulations that are approved. One is a fixed dose combination of tenofovir disoproxil fumarate with emtricitabine, and the other of tenofovir alafenamide. All three of these drugs are nucleoside reverse transcriptase inhibitors. Emtricitabine is dosed in its NRTI form, but both TDF and TAF are prodrugs. So once TDF is taken and gets absorbed into the blood, it's quickly broken down into its NRTI form, which is tenofovir, that then crosses into cells. TAF's a little different. TAF gets absorbed into the blood and then directly crosses into cells, at which point it's broken down into the NRTI form tenofovir by an enzyme called cathepsin A. Both emtricitabine and tenofovir are phosphorylated to their ultimately active form, tenofovir diphosphate and emtricitabine triphosphate, by kinases, and can also be dephosphorylated, so those phosphates get taken off, by phosphatases. Once inside the nucleus, these active forms compete with the local endogenous nucleotide pools for incorporation into the growing HIV DNA strand by reverse transcriptase. And if incorporated, nothing else can be added to the strand, so HIV integration is blocked. So with that in mind, I want to talk about the available PK for these drugs. And first I want to talk on the systemic or blood level. And I want to review something that is particularly important for us as we start to explore how modeling and simulation can help inform dosing, which is the concept of dose proportionality. So dose proportionality is simply a way to know that the concentrations that you achieve within a system scale predictably with the dose that you're given. And we know from single dose pharmacokinetic studies that this is the case for tenofovir diphosphate in blood cells. The top two graphs in this slide show you tenofovir diphosphate concentrations that were collected from PBMCs following single doses of tenofovir disoproxil fumarate or tenofovir alafenamide across a wide dosing range. And these data demonstrated statistically significant dose proportionality, meaning that with every R-fold increase in dose, there was an R-fold increase in concentration. Interestingly, we don't see that same trend for emtricitabine triphosphate, where when we give higher doses of emtricitabine triphosphate, there's no gain in concentration. And that's an important it's an important parameter for us to include when we model these data. These concentrations also scale with dosing frequency. So we know from the HPTN 066 study, which was a directly observed therapy study that looked at tenofovir disoproxil fumarate combined with emtricitabine in participants who took 1, 2, 4, or 7 doses per week. So we know, again, tenofovir diphosphate concentrations predictably scale with those dosing frequencies. And you can see this in our receiver operator curve, where there's a high level of sensitivity and specificity for tenofovir diphosphate concentrations predicting the dosing interval. So once we've understood how the pharmacokinetics of PrEP in the blood, we can start to drill down more and look at the pharmacokinetics of PrEP within the site, within anatomical compartments associated with the site of action. And before I get into these data, I want to give a disclaimer that the exact site of abortion that is achieved by PrEP is still unknown, whether it's the surface mucosal tissues or whether it's some deeper anatomical compartment. Data from tenofovir gel dosing, which demonstrate somewhat moderate efficacy, would suggest that mucosal tissue concentrations are an important factor, and that blood concentrations are not the only important factor. But probably the truth about where PrEP is acting lies somewhere in between mucosal tissue concentrations and the blood. For the purposes of this talk, I'll focus on mucosal tissue concentrations because these are easier to sample and we have more pharmacokinetic data, but I think that that's an important concept to review. So in studies looking at tenofovir disoproxil fumarate, we've seen quite consistently a trend that female genital tissue demonstrate lower concentrations than rectal tissue. And this can be seen in the graph on the left, where female genital tract concentrations for tenofovir and emtricitabine are plotted as a tissue to blood plasma ratio. And there's about a 100-fold increase between the female genital tract and the male rectum. And it can also be seen in the graph on the right, where the area under the curve for the active metabolites of tenofovir disoproxil fumarate and emtricitabine are plotted in both female genital tract tissue as well as female rectal tissue. And we see about a 10-fold difference in concentration there. This has also been observed for multiple dose studies. So I think I forgot to say the previous studies that I just cited were single dose. But the data that I'm showing here are multiple dose studies where uninfected participants took tenofovir disoproxil fumarate and emtricitabine, and rectal mononuclear cells and total cervical cells were isolated from biopsies and quantified for tenofovir diphosphate and emtricitabine triphosphate. And again, you can see over a 10-fold difference in concentration measured within the rectum versus the female genital tract for tenofovir. However, emtricitabine triphosphate is higher in the female genital tract. So everything that I've reviewed so far has been for tenofovir disoproxil fumarate, but how does tenofovir alafenamide stack up in this? And we don't have a lot of pharmacokinetic data from tenofovir alafenamide yet regarding tissue distribution, but there have been a couple of studies conducted. One is a single dose study that was conducted out of UNC, where we found that given a dose of tenofovir alafenamide versus tenofovir disoproxil fumarate, concentrations tended to be lower in the female genital tract for TAF, and the proportion of samples that were below our limits of quantification or our ability to see it tended to be higher. However, in a subsequent multiple dose study, we see the opposite trend. While again, there was a high proportion of samples in this study that were below the limits of quantification, here we see, given multiple doses of TAF, 25 milligrams, concentrations tend to be equal to or slightly higher than tenofovir disoproxil fumarate. And the proportion of samples that are below our limits of a quantification tend to be lower. So this gives us some evidence that tenofovir alafenamide given multiple doses may equally distribute into the female genital tract along with or as compared to tenofovir disoproxil fumarate. So how does this compare for the lower gastrointestinal tract or the rectum? With tenofovir alafenamide dosing in the rectum, we see lower concentrations of the prodrug tenofovir. And this is shown on the graph with concentration plot on the y-axis grouped by the dose that was given, TDF in blue and TAF in green. We also see that same trend in terms of the concentrations of tenofovir diphosphate, where the concentrations are about 13-fold lower in the rectum. We have limited data from lymph nodes that were recently published demonstrating that within lymph nodes, tenofovir alafenamide results in higher concentrations of tenofovir disoproxil fumarate, and also confirms findings that in the rectum, tenofovir disoproxil fumarate results in higher concentrations of tenofovir diphosphate. Another important finding in these studies is that lymph node concentrations tend to be lower than the concentrations in the blood. So when we talk about the site of action likely lying somewhere in between the mucosal tissue surface and the blood, you can think about lymph nodes lying somewhere in between, and these concentrations tend to be lower. For emtricitabine in the lymph node, this study demonstrated that concentrations tend to be higher than in the lower gastrointestinal tract and are consistent regardless of whether tenofovir disoproxil fumarate or tenofovir alafenamide are dosed. So now that I've gotten through a fair amount of the available PK data, I want to talk about how much is enough. And so this is where we start to marry what is achieved and how much is there with what is needed. And the first concept that I want to review is that of steady state, because steady state represents a best case scenario in terms of concentrations, and therefore it follows that the time to steady state may be a reasonable estimate of time to protection from PrEP, as well as the steady state concentration may be a reasonable target because it's the best that you're ever going to do. So here on this hypothetical graph, I'm showing a concentration time curve from a single dose where you can see a peak at an early time point, and you can see concentrations decline over 5 days. When we plot these data on a natural log scale, we can fit a regression line and understand what the clearance rate of this drug is by knowing what the slope of that regression line is. So here, the clearance rate tracks with a half-life of 20 hours. So the concept of steady state is one where the clearance of a drug equals the absorption of the drug, so the in equals the out, and the concentrations, there's no longer accumulation after initiating dosing. And because this principle tends to occur at 5 half-lives, we can predict what steady state concentrations would be if we know what the first dose concentrations are and the half-life. And you can see this prediction here. And you can see how as the individual approaches steady state with their dosing, the in and the out are really declining, and there's a leveling off of the concentration profile. So how can we employ that to understand when people are protected by PrEP? Again, steady state represents a best case scenario, and we know from pharmacokinetic studies what the clearance rate of the various forms of PrEP are in various compartments. And so here I've tabulated those from a study that was reported by Craig Hendricks's lab out of Johns Hopkins. And with a half-life of the tenofovir prodrug in the blood plasma of 17 hours, you can see that steady state is achieved, or the best that those concentrations are going to do in the blood plasma is achieved by approximately 3 days. However, because the half-life of tenofovir diphosphate in the female genital tract CD4 cells is around 140 hours, you can see that it takes about 20 days to reach steady state in the female genital tract. This begs the question about whether steady state is actually an overly conservative target when we think about PrEP effectiveness, because we don't see early infections in randomized clinical studies of PrEP, or a disproportionate number of early infections. But according to this concept, it would take almost a month of dosing for a woman to be protected. Also, in people who don't take the drug every day, they never reach these best case scenario steady state concentrations, yet we do see protection given less than perfect adherence. And so it allows us to consider whether there's a better way to identify a target for effectiveness. So the other PK/PD principle that I want to review is the concentration response relationship. And here in this hypothetical graph, you can see a concentration response curve where percent inhibition is plotted on a y-axis and drug concentration is plotted on the x-axis. By fitting a sigmoid regression curve to these data, we can understand what kind of inhibition, or predict what kind of inhibition would be achieved at unobserved concentrations or unobserved data points. And in doing this, we can identify an effective concentration 50, an effective concentration 90, and it goes on. You can identify an effective concentration 99, and use these to guide your targeted analyses. So how does that play out in data that we already have for PrEP? From the iPrEP study, we were really able to explore concentrations as a function of effectiveness, because the investigators did a wonderful job of collecting PBMCs fairly frequently. And a directly observed study of TDF dosing demonstrated that you could predict dosing behavior by PBMC concentrations. And so the iPrEP data are plotted, incidents within the iPrEP study are plotted as a function of PBMC concentration on the graph on the right. And you can see that 90% inhibition of infection is achieved at about 16 f-mol per million PBMC. I should state that these were cryopreserved PBMCs, which can impact concentrations and bias them low. And so it's hard to take this data point and extrapolate it widely. But this gives you proof of principle that targeting an EC50 or an EC90 can give you a good glimpse of an effective dosing strategy. Also, the problem with using PBMCs from the blood as your target concentration is that in order to extrapolate these data to other studies or to other populations that are not similar to the one in the present study, you have to make some assumptions that the site where HIV is going to be transmitted, so whether somebody is having receptive anal intercourse or insertive vaginal intercourse, you have to make the assumption that that site demonstrates the identical distribution pattern as the study population. You also have to make the assumption that dosing is the same. And here we're looking at a tenofovir diphosphate EC90 when it's combined with emtricitabine triphosphate. And so this really can't be extrapolated to potential dosing strategies of tenofovir diphosphate combined with lamivudine, for instance. So another way to explore how much is needed is to consider endogenous compounds that may mitigate potency of PrEP. And we know that the competing endogenous nucleotides that I mentioned earlier can impact PrEP potency from animal studies. So these data are shown on the graph on the left, where rhesus macaques that were dosed with tenofovir alafenamide that had lower ratios of DATP to tenofovir alafenamide, or let me say that in a different way, that had a lower proportion of tenofovir diphosphate when compared to DATP, became infected following a rectal challenge. And you see that with infected in red and uninfected in blue. Also, enzyme inhibition assays have shown us that given a standard concentration of tenofovir diphosphate, as you increase the concentration of DATP, the drug's ability to inhibit reverse transcriptase is severely blunted. And so this tells us that the concentration of these nucleotides at the site of action is an important consideration. And so one approach to finding an efficacy target is to conduct an in vitro study that allows us to explore the concentration response relationship for the metabolite when compared to the endogenous nucleotide. And this study was also conducted at UNC. And I'm showing the data here as percent protected on the y-axis across the molar ratio of the active metabolite to endogenous nucleotide on the x-axis. And you see that there's a very predictable relationship between those two parameters. And this allowed us to identify an EC90 for tenofovir and emtricitabine separately that could track with the drug's potency. However, this is looking at the drugs given alone. So one needs to ask before they employ this, but what is the effect of combination dosing? And so this can be done through a very large mathematical equation that I've put on this slide only to show you how complicated some of this math can get, and not to remember it in any way, shape, or form. But this equation allows us to essentially predict the effect of the drugs when given in combination across a large surface of concentration versus response. And so at UNC, we used the in vitro study that I just described in order to do this. And then we paired this target with a population PK model of the concentrations following tenofovir disoproxil fumarate dosing that are achieved in the female genital tract and rectal tissue. And when you take this approach, you can see that very early after dosing, high levels of the population are achieving these target exposures. suggesting that perhaps time to steady state is overly conservative. Another thing that pops out is that there's a difference in terms of the adherence level that is required to protect 100% of the population, with 100% being achieved at 7 doses per week, although I should say high levels of the population are achieving our target even at 5 or 6 doses per week in the female genital tract, and only 2 doses per week, achieving 100% target exposure in the lower gastrointestinal tract, which somewhat tracks with the clinical data that we've reviewed from the PrEP study and the PrEP study. So with all of that being said, I want to transition into potential endogenous or drug interactions that could mitigate the PrEP PK/PD relationship and should be considered when we think about widely implementing PrEP. And specifically, I want to talk about female sex hormones. So here you see across the female reproductive cycle, concentrations of estrogen and progesterone are highly variable. And yeah, that's all I wanted to say about that, sorry. And one thing I want to note is that in transgender women who are taking feminizing hormone therapy, concentrations of estrogen tend to track with the peak estrogen concentrations in that's observed in the female reproductive cycle. From the PK perspective, it's important to know that estrogen and progesterone have been associated with all kinds of changes to absorption, distribution, metabolism, and elimination pathways. They can alter gastric pH, they can change water retention, and all of these things can impact the pharmacokinetics of a drug. Additionally, estrogen may impact, and progesterone, sorry, may impact enzymes that are involved in that PrEP pharmacology pathway. And in the context of feminizing hormone therapy, this has really been studied, looking at the potential for feminizing hormone therapy to alter kinases, so the enzymes that turn PrEP into its active metabolites. And at Johns Hopkins, they have shown that while there's potential, theoretical potential, we really don't see that play out in the PBMCs or the tissues of transgender women who are taking feminizing hormone therapy. However, the other half of the enzymatic pathway, the phosphatases that break down these, are impacted by female sex hormones. And that's been shown in vitro studies where the activity of these phosphatases is increased in cells that are isolated from the female genital tract and treated with estradiol. Additionally, we can see that these hormones lower concentrations of tenofovir diphosphate when cells are isolated from the female genital tract and treated with both tenofovir and estradiol and progesterone. And so that makes us, or that should beg the question about whether transgender women are equally protected as men who have sex with men with PrEP dosing. And though they are disproportionately impacted by HIV incidence, they've really been underrepresented in our clinical trials that have enrolled both men who have sex with men and transgender women. However, despite this low enrollment, there has been some ability to explore through post hoc analyses their protection level within the studies. And one thing that has borne out is that in general, we see lower concentrations of tenofovir diphosphate in the DBS of transgender women in the PrEP trials. And many have suggested that this must be an indicator of lower adherence rates. However, it's important to note that logic line requires the assumption that pharmacology is matched. And if pharmacology is not matched between the two because of a drug interaction, then it's very possible that the lower concentrations aren't a function of lower adherence, but rather a function of a drug interaction. It's also important to note that when we plot the infection rate in these studies, grouped by study population, being transgender women or men who have sex with men, as a function of tenofovir diphosphate concentrations, again, we see a predictable relationship between the two that appear to mirror one another, but with transgender women having a much more variable response in terms of infection at high levels of concentration. So I want to get through some data that looks at whether the pharmacokinetics of PrEP may be altered in transgender women taking feminizing hormone therapy. And across multiple studies now, we've seen that the prodrug tenofovir in plasma is lower for transgender women versus cisgender men, shown on the graph to the left, with concentration on the y-axis and time after last observed dose on the x-axis, as well as when we compare transgender women to a population of cisgender men and women. And this is shown on the graph in the right. However, because tenofovir plasma concentrations aren't necessarily a good predictor of what's going on at the site of action, these data leave us scratching our heads some about whether they are meaningful or not. And so it's important to explore what's going on at the typical site of transmission for transgender women, which is the lower gastrointestinal tract. And we've seen across a couple of very small observational studies now, concentrations of the active metabolite when explored by themselves tends to be lower in transgender women when compared to cisgender men. And these data are from tissue biopsies where they isolated colon cells and quantified active metabolites and saw about a 30 to 40% reduction in concentration between their two populations. Also, when we look at these concentrations as a function of that endogenous nucleotide, DATP, in the lower gastrointestinal tract, we see that concentrations are again statistically significantly different, really warranting further exploration in larger, more purposeful studies. And so I think I'm actually going to skip through my adherence section, if that's all right, because I want to leave time for questions should we have any. And it looks like I have gone long, and I put too many slides.
Mackenzie, you're okay. Right now, there's nothing in the chat.
Okay.
So take your time with what you want to do.
Okay. Well, then let's see how much of this I can get through. I'll go quick, or I'll try to go quick. So you see my first slide again with a little tweak on the plot of effectiveness versus adherence measure, where I've added a relationship for effectiveness versus pill count as a subjective measure of adherence. And when you fit a regression line to these data, you see that there's a statistically significant relationship between PrEP effectiveness and drug concentrations, but not between PrEP effectiveness and pill count. And so this really speaks to the fact that we need good biomeasures for understanding how well our patients and our study participants are taking their PrEP in order to target adherence strategies and messaging to those people who need it most. And so I want to review a couple of different techniques for measuring adherence, and then I'll focus on what is most commonly done. We have both short-term measures of adherence and long-term measures. And short-term really come down to looking at the urine or looking at the plasma, where the half-life of tenofovir and emtricitabine are quite short, and you quickly reach steady-state concentration, so there's very little accumulation. And so when we explore those concentrations of as a measure of adherence, our test can really be tricked by the fact that there's so much overlap in concentrations given very, very early after someone starts dosing. So essentially, if someone takes a dose the day before the test, although they've never dosed before, the test will tell you that they have the same concentration as if they had been dosing every single day before. So for this reason, the field has really moved towards looking at long-term measures of adherence. So those places in the body where PrEP has a longer half-life, like the PBMCs or the dried blood spots. And here you can see in my hypothetical scenario, because there's so much accumulation, and accumulation occurs for such a long period of time after someone starts dosing, that there's really no overlap in terms of the concentrations between the second and the 20th dose. And so if somebody comes into the clinic and they've just taken a single dose, our test won't be fooled by that behavior. The problem with using long-term measures is that they fail to account for recent changes in behavior once somebody hits that steady state. And you can see that in the blue curve, where the 120-hour hypothetical simulation results in very little change in concentration after someone stops taking the dose for about a week from about the 4th dose. And so the test can be fooled if somebody who was taking the drug perfectly stopped taking the drug immediately before their clinic visit. Even despite that, we've seen a significant relationship between these long half-life measures and effectiveness of PrEP. Here you can see for tenofovir diphosphate in dried blood spots that there's a significant relationship among people who are taking very few doses per week, so 33% of doses in red, a moderate amount of doses per week, 67%, and a high amount, 100%. And these data have been employed to the IPREX study. I didn't show this graph again, but you've seen it multiple times, and shown a statistically significant relationship between DBS concentration and the likelihood of infection, telling us that this is probably a better measure of adherence and what's been going on with dosing than plasma. This is the same for tenofovir alafenamide. Here you can see concentrations of tenofovir diphosphate in DBS when somebody is taking 100% of their doses in green, 67% of their doses in yellow, and just 33% of their doses in red. And you can see that this technique, when you take a larger proportion of your dried blood spot for the assay, scales with concentrations that have been measured for TDF. Another technique that we can use to explore the long-term measures of adherence is hair. And this is a really nice non-invasive technique. And the data that I'm showing are for hair ground up and given as an average concentration. And you can see as concentration, that concentration predictably increases with dosing behavior in the graph on the left, and that these scale with dried blood spots in the graph on the right. However, given the early limitation that I mentioned with these long-term adherence strategies, one technique that's being explored out of UNC to even further drill down into hair as a measure of adherence is to, rather than grind the hair up and get an average concentration, to explore concentrations in a intact hair strand from the follicle to the end as a better dose-taking diary. And while I don't have a slide on that, data will be forthcoming in the next couple of years demonstrating whether this novel technique is adequate and could be employed in the clinical environment. So I guess, Jill, thank you for telling me I could keep going, because I did get through all of the slides. This is my summary slide. So to summarize, PK studies and PK/PD modeling indicate that PrEP pharmacology differs between transmission sites for both TAF and TDF, and that in general, concentrations of PrEP or of tenofovir diphosphate are lower in the female genital tract when compared to the gastrointestinal tissue. And that when we use modeling and simulation against an EC90 target concentration, we really see that bear out in that cisgender women need to do just a little bit better in terms of dosing than men who have sex with men in order to be protected from by PrEP. We also see that gender affirming feminizing hormone therapy may decrease both systemic blood and rectal concentrations of PrEP for tenofovir disoproxyl fumarate, but no word on whether this is the case for tenofovir alafenamide. And it's also important to state that these data come from very small clinical studies, which really warrant further study. And UCSD will be initiating a clinical study today, in fact, to get a better bead on whether we see this in a more diligent design. Also, with pharmacologic measures of PrEP, i.e. DBS and hair, correlate with PrEP effectiveness and may offer a better measure of adherence than subject report, as well as than plasma concentrations. And so with that, I want to take you to my last slide, which is a picture of our very large group at the UNC CFAR Clinical Pharmacology and Analytical Chemistry Core. I also want to put in a shameless plug that if anybody in the audience needs a concentration measured anywhere in the body, I personally think we're the best in the business for doing that. We love the studies that bring us all kinds of weird samples. The blood samples tend to bore us. And I also want to disclose and thank my funding sources. And that's it.
Thank you, Mackenzie. There's one question in the chat, which may take up the rest of your time because I think it's an interesting one. This is from David Moore, one of our collaborators on lots of our PrEP studies, who says, lovely talk. And given all these data, what are your thoughts on intermittent and on-demand PrEP?
Yeah, so I definitely think that intermittent and on-demand PrEP are supported by both clinical study and by modeling and simulation for men who have sex with men. I get a little bit concerned about it when we talk about cisgender women, because the data the modeling and simulation data don't demonstrate as sustained of concentrations following the dosing as in the lower gastrointestinal tract, which is unfortunate, because if they were equally sustained, then we could say, well, we can take the clinical data from men who have sex with men and we can employ that and say, well, this long in the lower gastrointestinal tract worked, so this long in the female genital tract should also work. But given that the models don't match, I get just slightly angsty about talking about intermittent for women outside of having any kind of clinical data to support it. For transgender women, I also get angsty, although I may be one of the few pharmacologists, maybe I'm overly conservative. I think it makes me a little angsty because they've been underrepresented in the clinical studies. We have tended to see more incidence in that population amongst the study participants who do get enrolled. And, you know, we really don't know enough, in my opinion, about how those feminizing hormone therapy regimens may alter concentrations at the site of action to feel confident in that strategy given the limited clinical data. So that was a pretty lengthy explanation. Those are just my thoughts. There's a lot of debate out there about it. I'm just one person, but that's my opinion.
Thanks, Mackenzie. And thanks from David. He wrote it the same time I said it, so we were thinking alike. Does anyone else have any questions for Mackenzie? This was an amazing talk, Mackenzie, and I always appreciate hearing from you. Your data is really, it's very compelling, and I think really has propelled the field in a lot of ways. And I look forward to continued collaborations with you. My shameless plug for Mackenzie is that this is now the second study we'll be doing with her, and we will hopefully have some forthcoming data from our cisgender women in a PrEP study who we have to analyze the data, but or to get it really out there. But she's wonderful to work with, so I certainly encourage it. But yeah, I think that's it. So thanks so much. Thanks, everybody. We'll talk to you soon. Thanks, Mackenzie.
Thank you.
Bye.